Hi everyone, our subject today is irritable infant, fuzzy or excessive crying and colic. Basics. Crying is usually a normal physiologic response to stress, discomfort, unfulfilled needs such as hunger, pain, over or under stimulation or temperature changes. Crying is felt to be potentially pathologic if it is interpreted by caregivers as different in quality and duration without apparent explanation and or persistent without consolability beyond a reasonable time, generally 1 to 2 hours. Infantile colic is not diagnosis. It is simply a term that describes healthy infant with the paroxysmal excessive crying for no apparent reason, presumably of intestinal origin, during the first 3 to 4 months. Around 5% of cases have organic causes. Crying may be a baby's way of communication. As children grow older, they find different ways to communicate. Rule of 3 Whistle criteria. Colic is defined as crying in an infant who is well fed and healthy, that is, more than 3 hours per day, more than 3 days per week, for more than 3 weeks. 10 to 14% of infants are affected, typically begin at 2 to 4 weeks of age, peaks at 6 weeks, and resolve typically by 4 months of age, but timing and length of crying spell are variable. Often crying spells demonstrate a diurnal pattern with the increased crying late afternoon and early evening. Incidence does not vary by gender, breast or formula fed or prematurity. History of colic, suggestive of colic, able to be soothed, absence of fever, increasing after 3 to 4 weeks of age, late afternoon and evening crying, peak crying at 6 weeks of age, period of normal happy behavior. Mother has symptom of postnatal depression. Crying shortly after feeding suggests aerophagia or gastroesophageal reflex. 1 hour after feeding suggests formula intolerance. A rare cause of postprandial crying is anomalous coronary arteries. Overfeeding or underfeeding, excessive air swallowing, inadequate burping, and improper formula preparation may contribute to excessive crying. Suggestive of organic cause of colic, if there is apnea, cyanosis, fever, respiratory distress, complication in the perinatal period, history of underlying condition, history of possible ingestion exposures, rash, forceful vomiting, recent illness. Other important history point: allergies, attempt medical treatment, family history, homeopathic, natural, cultural treatment, sibling temperament, stooling pattern. Fever significance indicate potential need for evaluation of meningitis and other infection. Paradoxical increased crying attempt at consolation make the crying worse, especially with the lifting or rocking. Significant can be seen in meningitis, peritonitis, long bone fracture, and arthritis. Question about stridor significance imply possible upper airway obstruction, mechanical, functional. Question expiratory grunting significant indicate higher likelihood of significant pathological cause of crying, especially cardiac, respiratory, and or infectious disease. Question cold symptom and or daycare attendance significant increased likelihood of otitis media. Vomiting significant increases likelihood of pathologic GI causes, obstruction, gastroesophageal reflux with possible esophagitis, particularly in infant less than 3 months of age, or CNS disease. Question recent fall or trauma significant may indicate possible fracture, increased intracranial pressure, abuse. Question documented weight loss outside the 2 week of neonatal period suggests an organic cause. How might the quality of crying be helpful in the diagnosis? high-pitched, shrill, piercing crying in short bursts associated with CNS pathology, especially with the increased intracranial pressure. High-pitched crying in longer bursts seen in a small for gestational age infant, neonatal drug withdrawal. Hoarse cry seen in hypothyroidism, laryngeal disease, hypocalcemic tetany. Weak cry may be seen in neuromuscular disease, infantile botulism, and or the very ill infant. Cat-like cry can be associated with the cry-du-chat syndrome, 5pq deletion syndrome. Physical examination. Remove all clothing and perform a thorough cardiac, respiratory, abdominal, and skin exam to look for sign and symptom of systemic illness. Lethargy, tachypnea, or poor perfusion are signs of serious illness. Rash, orifice, tight phimosis, pressure, white patch on oropharynx, erythematous ear canal or tympanic membrane, scleral injection. Perform an age-appropriate neurological exam. Plot the child on the growth chart, weight, height, and head circumference. Failure to gain weight and poor growth are likely to point to an organic infectious cause. Vital sign with temperature more than 38 Celsius consider infectious etiology. Observation of the child being held by parents gives clue to parents bonding and also consolability of the infant. Finding infant appear ill, like pallor, grunting, poor arousability, poor response to social overstimulation, significant imply much higher likelihood of an organic cause. Finding tenderness on palpation of extremities, clavicle, or scalp, or painful or decreased range of motion of joint, significant suggest fracture, subluxation, osteomyelitis, septic arthritis. Finding conjunctival redness, eye tearing, scratched near the eye, significant suggest corneal abrasion, fluorescein testing of the eye warranted, or foreign body in the eye, eversion of the lid recommended. Cessation of crying with the ophthalmic anesthesia drop while doing fluorescein staining suggests corneal injury as a cause. Finding impacted or bloody stool on rectal exam, abdominal mass suggests constipation or intussusception. Finding geographical scar, frenulum, tear, retinal hemorrhage, suspicious bruises, burn, decreased weight, height ratio, significant suggest neglect, abuse, physical, emotional. Bruised are rare in pre-ambulatory children, particularly below 6 months of age. If present, consider inflicted injury. Finding bulging or full fontanelle, especially in upright, quiet infant, significant indicate possible increased intracranial pressure, meningitis, subdural hematoma, vitamin A toxicity. Finding edema of the individual toes, finger, or penis, significant suggest hair tourniquet syndrome. Finding tender swelling in inguinal or scrotal area, significant may indicate incarcerated hernia, testicular torsion. Finding heart rate more than 200 with the minimal variability, significant indicate possible SVT. Finding hypothermia suggests infection or hypothyroidism. How to approach to irritable infant after performing history and physical examination. Is the diagnosis suggested by physical examination? If it is yes, differential diagnosis, tourniquet syndrome, foreign body in the eye, otitis media, teething, stomatitis, corneal abrasion, congestive heart failure, intussusception, other causes of acute abdomen, testicular torsion, food protein-induced enterocolitis, tachyarrhythmia, hand-foot syndrome, sickle cell disease, shaken baby syndrome, child abuse, septic arthritis, osteomyelitis, anal fissure, constipation, encephalitis, meningitis, pseudotumor cerebri, bite, insect bite, spider, incarcerated inguinal hernia. If it is not suggested by physical examination, is the baby consolable during time of observation, looks well? If it is yes, If there is evidence of tooth eruption, symptom compatible with the teething. If it is yes, this is teething. If it is no, is it first episode? If it is yes, observe for 24 hours. If the irritability resolved, differential diagnosis, normal infant, vaccine reaction, teething, constipation, overstimulation, or viral illness. If it is not the first time or the baby not resolved within 24 hours, differential diagnosis, history, symptom compatible with colic, normal growth and development, history similar of episode, predominantly evening occurrence, normal between episode. If it is yes, this is colic, normal infant, or constipation. If it is not, if the baby inconsolable or poor consolable during time of observation, or irritability persistent or recurrent after 24 hours, patient need urine analysis, urine culture, consider complete blood count, stool, Colic, fecal, occult blood, urine, drug screen. If it is abnormal result, differential diagnosis, UTI, pyelonephritis, other serious bacterial infection, osteomyelitis, discitis, septic arthritis, meningitis, intussusception, enteritis, allergic, infectious, drug, toxin, including abstain syndrome, sickle cell disease, pain crisis, anemia, constipation, fissures. If it is a normal result, history of GI symptom, vomiting, loser stool, blood in stool, micro or macro. If it is yes, a trial of hypoallergic formula. If the symptom resolve, this is milk protein induced enterocolitis. If it is not resolved, or if the patient does not have GI symptom or symptom not resolved on hypoallergic formula, patient need complete blood count, stool, Colic, fecal, occult blood, urine, drug screen if not already done. Consider additional workup for diagnosis not evident versus follow-up in 24 hours. Skeletal survey of bone or bone scan, fluorescein eye stain, head CT, LP, do CT before LP, ophthalmological result consultation, ECG, upper GI endoscopy, in-house observation. Differential diagnosis could be intussusception, enteritis, allergic, infectious, child abuse, intracranial hemorrhage, fracture, brain tumor, pseudotumor cerebri, drug, toxin, including abstain syndrome, sickle cell disease, pain crisis, serious bacterial infection, osteomyelitis, discitis, septic arthritis, meningitis, metabolic disorder, hyponatremia, hypoglycemia, hypocalcemia, encephalitis, anemia, GERD, SVT, anomalous coronary artery, myocardial ischemia, parenteral anxiety, normal infant. Approach to the patient. If the initial history and physical examination do not suggest diagnosis, consider the ability to consult the infant during evaluation. An infant who can be consulted during the initial period of observation and has normal result on physical examination is not likely to have a serious illness. Follow-up should be recommended within 24 hours for any infant being evaluated for excessive fuzziness or crying, even if the consolable or diagnosis seem evident. Sometimes an alternative or definitive diagnosis may become evident within 1 or 2 days of the initial presentation. In addition, parents should be counseled carefully about worrisome sign and symptom and reason for follow-up sooner. Recommended investigation, history and physical exam rather than extensive lab testing are the key to the diagnosis. In Friedman Emergency Department study of more than 200 excessive crying infant, less than 1% had testing contribute to diagnosis in the absence of suggestive clinical picture. Urine analysis to exclude UTI, complete blood count, C-reactive protein for infection such as appendicitis, plain X-ray of abdomen for intestinal obstruction like intussusception, abdominal ultrasound scan for renal or gallbladder stone, intestinal obstruction, pH study to confirm gastroesophageal reflux, stool for occult blood for possible interception and anal fissure. Fluorescein testing of eye for corneal abrasion may occur without significant conjunctival redness. Urine toxicology screen for drug withdrawal, neonatal period, ingestion, passive exposure, like cocaine. Pulse oximetry for hypoxia from cardiac causes may cause increased irritability. Electrolyte panel blood glucose for endocrine or metabolic disturbance, especially if abnormal sodium, hypocalcemia, significant acidosis, or elevated anion gap. Skeletal survey for suspected abuse. Also consider MRI or head CT scan for those less than 1 year of age with the suspicious injury. Alert! Factors that make this an emergency include the following: suspicion of meningitis, stiff neck, bulging fontanelle, fever, especially in infants less than 3 months of age, suspicion of intestinal obstruction, vomiting, especially bilous or projectile, mass on abdominal palpation and or bloody stool, suspicion of incarcerated hernia or testicular ovarian torsion, evidence of cardiac compromise, congestive heart failure, SVT, tachycardia, poor perfusion, capillary refill more than 3 seconds, poor distal pulses, rales, evidence of acute dehydration, weight loss, decreased urine output, orthostatic changes, poor perfusion. The diagnosis of colic should not be made without excluding more serious disorders such as otitis media or interception. A child who develops severe paroxysmal abdominal pain after the age of 3 to 4 months should be examined to exclude organic causes like UTR or interception. Be aware that fontanelle can be bulging when the baby is crying. If it remains so after cessation of crying, this sign is serious and occur in meningitis or hydrocephalus. The administration of a sedative to a child with the persistent crying may mask an underlying abdominal pathology. It should be the last resort. Be aware of possibility of non-accidental injury for unexplained baby crying. Check the baby's weight, failure to thrive. Check for any bruises in the skin. Early increase in crying in a healthy infant is the most common stimulus for shaking baby syndrome, abusive head trauma. This is a potentially lethal form of physical abuse causing brain injury, subdural hematoma, with the 80% significant brain injury and 20% death. Tourniquet syndrome refers to a thin filamentous material, hair, thread, that has wrapped around a bandage and is causing vascular compromise. Careful examination of digits is essential. Finger, toes, penis, and even the uvula have been reported as affected site. An area of well-demarcated discoloration or swelling on a distal appendage is suspicious. Be aware that occupying edema and duskiness can obscure strangulating item, making diagnosis difficult. Rapid diagnosis is necessary to minimize morbidity. Surgical intervention is frequently needed, especially for cases of penile strangulation. Interception typically present with the sudden onset of paroxysmal colicky episode of pain. Vomiting is common. Affected infant and toddler are initially normal between episodes and gradually become weaker and more lethargic. Most cases, about 60%, will pass stool with the gross blood and mucus, current jelly, but this may not occur for up to 1 or 2 days after symptom onset. Abdominal ultrasound followed by enema, air, saline, water-soluble contrast is the performed diagnostic and therapeutic approach. Protein-induced enterocolitis. In mild cases, non-IgE mediated hypersensitivity or food allergy may present with a very non-specific symptom: spitting, slightly loose stool, fuzzy. Fecal occult blood is frequently positive. Consider a trial of hypoallergic formula if suspicious of the diagnosis. consider allergy consultation for long-term recommendations. Hand-foot syndrome, dactylitis, is often the first clinical manifestation of sickle cell disease. Infant present with the irritability and painful, usually symmetric, swelling of the hands and feet. Teething. Patients' family often suggest teething as a cause of excessive crying, as well as fever, diarrhea, rash, etc. Objective data do not support a strong association. Be careful in ascribing symptom and sign to teething. Most infants start teething around age 6 months. Evidence of erupting teething, increased salivation, and relief with the chewing on a cold object suggests teething. Normal crying may be reported as excessive by inexperienced or stressed parent. Normally, crying increases from birth until about 6 weeks of age, with an average maximum 2.5 to 3 hours per day. The crying tends to be concentrated between 3 and 11 p.m. A wide range of normal variation in crying time is recognized. An acute change in child's crying pattern is more worrisome than actual duration. Vaccination. Mild fuzziness is associated with several forms of the standard childhood vaccines. Local soreness at the injection site is generally considered the cause. Significant irritability related to vaccine is unusual. Other etiology should be considered. Abstinence syndrome may occur in infants born to substance-abusing mother. Withdrawal symptoms include irritability, vomiting, diarrhea, hypertonicity, poor feeding, and sleep problems. Withdrawal usually occur in first week of life but may be delayed up to 2 to 3 weeks if the mother was using methadone. Beyond the neonatal period, breastfeeding infant may experience fuzziness and irritability due to transfer of maternal drugs, decongestant, caffeine, nicotine, cocaine. Environmental toxin, carbon monoxide may rarely be cause of nonspecific infant fuzziness. Meningitis need to be considered in a case of severe or inconsolable irritability. Some infant will present afebrile. A head CT should be obtained before performing an LP in those infants to rule out increased intracranial pressure. Inborn error of metabolism should be considered when there is associated vomiting, neurological symptom, failure to thrive, or a positive family history, including unexplained neonatal death. Acidosis, hypernatremia, hypocalcemia, and hypoglycemia are rare but serious cause of irritability in infants. Fears and pitfall. Gas does not cause colic. Excessive crying that accompany colic usually lead to aerophagia. Excessive crying has been linked to parental distress and, in rare instances, serious illness or infant abuse. Medications are not routinely recommended for colic. Although several over-the-counter preparations are used for colic, grape water, infantile, and other, they are significantly not improved. Prognosis, parental reassurance, and support remain the main step of treatment of infantile colic. Persistent crying beyond 4 months of age has been associated with long-term psychosocial and behavioral problems, including hyperactivity and migraine. Thank you for your listening.